This lecture is about Crossbite. In normal overjet, there is an overlap of maxillary teeth to the mandibular teeth, labially and buccally, while in case of crossbite, this relation will be reversed, so that the lower teeth will overlap the upper teeth. Therefore, crossbite is a discrepancy in the buccolingual relationship of the upper and lower teeth. So this buccolingual relationship will be reversed in case of crossbite. It's usually described according to the position of lower teeth in relation to the upper teeth. So if the lower teeth is buccally positioned to the upper teeth, this is buccal crossbite, while if the lower teeth positioned lingually or palatally to the upper teeth, this is lingual crossbite. Under normal circumstances, the maxillary arch overlaps the mandibular arch both buccally and labially, as mentioned before. Here you can see some examples of crossbites. In this case, you can see the maxillary centrals and laterals all are in crossbite. Another example of anterior crossbite. This is normal relationship. You can see a normal overlap of the maxillary teeth, both labially and buccally. And in this case, you can see bilateral buccal crossbite with a crossbite of lateral incisors. Classification of crossbite. Crossbite can be classified based on the etiological structure or according to the location. For the etiological structure, this crossbite could be dental crossbite, skeletal crossbite, or functional crossbite. While based on the location, crossbite could be anterior or posterior crossbite. So according to the etiological structure, we have dental crossbite, skeletal crossbite, and functional crossbite. Dental crossbite is usually confined to the dentition with no skeletal or bony involvement. In case of skeletal crossbite, this could happen due to malposition or malformation of the jaws. For example, maxillary retrognathism, mandibular prognathism, or combination of both. This could happen usually in skeletal class 3 malocclusion. In case of functional crossbite, this usually appears when we have occlusal interference or premature contact between the upper and lower teeth, and this could lead to displacement of the mandible anteriorly or posteriorly in order to achieve maximum intercuspation, and this will be associated with crossbite either anteriorly or posteriorly. For example, in case of pseudo-class 3 malocclusion, the unilateral posterior crossbite may appear due to displacement of the mandible laterally. These are examples of dental and skeletal crossbite. You can see in case of dental crossbite, this happened due to displacement of a tooth, leading to the development of dental crossbite. While in case of skeletal crossbite, you can notice that there is a discrepancy in the position of the bone. This could be retrognathic or this could be prognathic. So there is a bony involvement in case of skeletal crossbite. In case of functional crossbite, there is a shifting of the mandible either anteriorly or posteriorly. So This case is functional anterior crossbite. You can notice that in centric relation there is a premature contact of the anterior teeth, and in order to achieve maximum intercuspation, the patient protrudes the mandible anteriorly, but at the same time develop anterior crossbite. So this crossbite is due to shifting of the mandible anteriorly, which happened due to anterior or premature contact of the anterior teeth. In case of functional posterior crossbite, there is also a premature contact, usually posteriorly. So in order to avoid this premature contact, the patient move or shift the mandible to one side. In this case, the mandible is shifted to the right side and developing posterior crossbite here. This can be identified by noticing the anterior midline. So in this case, you can see the coincidence of upper and lower midline, while in case of shifting, you can notice that the midline is shifted to the right side. Based on the location, crossbite can be divided into anterior and posterior crossbite. Anterior crossbite can be subdivided into single tooth crossbite or segmental crossbite, while posterior crossbite can be subdivided according to the number of teeth into single tooth crossbite or segmental crossbite, or according to the existence of the crossbite on one or both sides of the arch into unilateral crossbite and bilateral crossbite, or according to the extent of the crossbite into buccal crossbite and lingual crossbite, which is called scissor bite. Here are some examples of crossbite. This is single tooth crossbite anteriorly, and this is also anterior crossbite of single tooth. This is anterior crossbite of segmental teeth, and this is again segmental crossbite of anterior teeth. So in these situations, we have anteriorly positioned crossbite, although in this case you can also notice that there is a posterior crossbite. This is a posterior crossbite of single tooth, and this is bilateral crossbite of segmental teeth posteriorly and segmental anterior crossbite anteriorly. This is the lingual crossbite of segmental teeth posteriorly, and this is again segmental lingual crossbite posteriorly. This is called lingual because the buccal cusp of the lower teeth occlude lingually to the palatal cusp of the upper teeth. In case of anterior crossbite, the mandibular anterior teeth overlap the maxillary anteriors, so there is a reverse overjet. This could happen due to lingual position of the maxillary anterior teeth in relation to the mandibular anterior teeth, and as mentioned before, this could be single tooth crossbite or segmental teeth crossbite according to the number of teeth in crossbite involved, or it may be or may not associated with forward displacement of the mandible. In posterior crossbite, there is abnormal transverse relationship between upper and lower posterior teeth. Again, it could be single tooth crossbite or segmental crossbite, it could be unilateral or bilateral, or it could be buccal or lingual crossbite. Buccal crossbite the buccal cusp of the lower teeth occlude buccally to the buccal cusp of the upper teeth. So this is the buccal crossbite. Lingual crossbite, in which the buccal cusps of the lower teeth occlude lingual to the lingual cusp or palatal cusp of the upper teeth. So this is a lingual crossbite due to lingual position of the lower teeth. And this is called scissor bite. Posterior crossbite can be usually seen as unilateral buccal crossbite with displacement, usually arises when the mandibular displacement laterally happen due to presence of deflecting contact either from the displaced tooth or because of the narrowing of the maxillary arch, which results in cusp-to-cusp relationship of the posterior teeth in occlusion. So due to this premature contact, the mandible is shifted laterally in order to achieve maximum intercuspation, and this leads to development of unilateral crossbite with displacement. Or it could be seen as unilateral buccal crossbite without displacement. Usually arises either due to displacement of a tooth, or it could be due to underlying skeletal asymmetry of the dental arches. When a greater number of teeth involved, usually this is due to skeletal problem, and when there is small teeth involved, this could be due to displacement of a tooth or teeth. Bilateral buccal crossbite usually associated with skeletal discrepancy like skeletal class 3. Unilateral lingual crossbite usually due to displacement of teeth as a result of crowding. Bilateral lingual crossbite or scissor bite usually associated with skeletal discrepancy of class 2. So these are the situations that can be seen in case of posterior crossbite. Could be either unilateral buccal crossbite with displacement or without displacement, bilateral buccal crossbite, unilateral lingual crossbite, or bilateral lingual crossbite or scissor bite. This is a buccal crossbite of posterior teeth, and this is a lingual crossbite of posterior teeth. This is again buccal crossbite of the molar. This is bilateral buccal crossbite of the posterior teeth, and these two cases are lingual crossbite. Now you will see a short video about functional anterior crossbite when there is a displacement of the mandible anteriorly. You can notice this premature occlusal interference leading to shifting of the mandible anteriorly and developing of anterior crossbite. This is a case of functional posterior crossbite. You will see how the mandible is shifted or displaced laterally to develop a posterior crossbite or unilateral posterior crossbite. This usually happens due to narrowing of the maxillary arch slightly, and due to this narrowing there is a premature contact of the posterior teeth, as you will see. And due to this premature contact, the mandible is shifted to one side, and you can notice the midline how it is shifted to that side. Etiology of crossbite. Etiology of dental crossbite could be due to crowding when there is lack of space in the dental arch, or some anomalies of the teeth like number, size, shape like supernumerary teeth or macrodontia, or it could be due to premature loss or prolonged retention of primary teeth, leading to crowding and displacement of the permanent tooth into crossbite position, or due to occlusal interference or prematurities. So these are four possible etiological causes of dental crossbite. So you can see in this case, due to lack of space, there is crowding of upper anterior teeth and displacement of maxillary lateral incisors into crossbite position. In this case, there was a premature extraction of maxillary second primary molar, leading to loss of space and displacement of maxillary second premolars into crossbite position. In this case, you can notice a supernumerary tooth is positioned into crossbite position. And the premature occlusal contact, either anteriorly or posteriorly, can lead to development of anterior or functional anterior crossbite or functional posterior crossbite. Now, etiology of skeletal crossbite. As we said, skeletal, this is related to bone. So this could be due to hereditary or discrepancy in the size of dental arches, for example, skeletal class 3 or skeletal class 2, or due to habit, like thumb sucking, mouth breathing, or due to cleft lip and palate, where the scar tissue of the cleft repair can restrict the maxillary growth, sometimes due to trauma or pathology of the TMJ, it can restrict the mandibular growth. As a general rule, the greater number of teeth in crossbite, the greater is the skeletal component of the etiology. You can notice here there is a discrepancy in the size of the maxillary arch and the mandibular arch. This could be due to small maxillary arch or large mandibular arch. In case of thumb sucking, the negative pressure can lead to narrowing of the maxillary arch, leading to the development of crossbite. And in case of cleft palate, the scar tissue restricts the maxillary growth, leading to the narrowing of the arch and developing of crossbite. Crossbite, whether it was anterior or posterior, especially if it was associated with functional shifting of the mandible or mandibular displacement, should be corrected as soon as they are detected. If the condition is left untreated, it may develop into severe skeletal malocclusion. So starting with the anterior crossbite correction. Treatment options of anterior crossbite. In case of dental anterior crossbite, either we have tongue blade therapy, removable orthodontic appliance, or fixed orthodontic appliance. In case of skeletal anterior crossbite in growing patient, we have orthopedic appliances or functional appliances. while in case of skeletal anterior crossbite in adults, we have a surgical correction. So these are the treatment options in case of anterior crossbite. Dental anterior crossbite. The first option is tongue blade therapy. This can be used in treatment of developing anterior crossbite by biting on a wooden tongue blade using the lower teeth as a fulcrum for a period of 5 to 10 minutes daily. This can help to redirect the mandibular and maxillary anterior teeth into normal relationship. Removable orthodontic appliance can be used with the Z-spring to correct single tooth in crossbite, recurved Z-spring in order to correct more than single tooth in crossbite, or screw to correct single or segmental teeth in crossbite. These three options can be used to correct anterior crossbite. We should use posterior bite plane in case of removable appliance in order to open the bite anteriorly so that we have freedom to move the cross-bited tooth. These are options of removable appliances to correct anterior crossbite. You can see this is the spring, posterior bite plane, retentive component, and acrylic base plate. This is a screw used for correction of anterior crossbite, and there is a screw for correction of posterior crossbite. This is a screw used for correction of single tooth, and this is a screw used for correction of segmental teeth in crossbite. This is a recurved Z-spring, can also be used to correct segmental teeth or more than one tooth in case of anterior crossbite. If the correction of anterior crossbite required bodily or apical movement of the tooth in crossbite, in this case we need to use fixed appliance in order to move these teeth in crossbite, because we cannot achieve this type of movement with removable appliance. So these are the options of correcting anterior dental crossbite, starting from the tongue blade therapy, removable appliance, and if we have bodily or apical movement, we can use fixed appliance. This short video will show you how to correct anterior crossbite with removable appliance using a screw. This is a screw to correct segmental teeth in crossbite anteriorly, and you can notice the posterior bite plane to open the bite and free the anterior teeth in order to move labially. By opening the screw, turning the screw, this plate can be moved anteriorly and pushing the teeth into correct position. Continuing with the correction of anterior crossbite, if we have skeletal anterior crossbite in a growing patient. In this case, we can use orthopedic appliances, for example, face mask with rapid maxillary expander when we have skeletal anterior crossbite due to maxillary retrognathism, or chin cup when we have skeletal anterior crossbite due to mandibular prognathism. So these can be used, one in case of maxillary retrognathism and the other, which is the chin cup, in case of mandibular prognathism. Or we can use functional appliances like Frankel 3 that can be used to correct developing skeletal class 3 with anterior crossbite. Options. This is a face mask, which is a Delier type, and this is also a face mask called a PT type. This is a chin cup, and this is Frankel 3. If we have skeletal anterior crossbite in adults, in this case we need to use surgical correction, for example, mandibular setback or maxillary advancement surgical procedures. So the figure above is about mandibular setback, and the figure below is about maxillary advancement. This case can be, or this treatment option can be used in case of correction of anterior crossbite, which is of skeletal origin and in adults. Now correction of posterior crossbite. This is usually achieved by expansion of the upper arch or segment of the arch, and it's important to evaluate the inclination of the affected tooth from the beginning. Is that if the teeth in crossbite are palatally tilted, the treatment will be more stable by expansion of these teeth than in case where the teeth in crossbite are normally inclined. Treatment options of single tooth in crossbite are: first, extraction of the tooth in crossbite if it's totally excluded from the dental arch or if it's severely displaced. Second, by movement of the displaced tooth into the line of the arch using either removable appliance with screw or T-spring, or with fixed appliance if bodily movement is required. We can also use fixed orthodontic appliance with cross elastics in case of when correction of crossbite is required movement of the opposing teeth in opposite directions. In these cases, you can see that the tooth in crossbite is totally excluded from the dental arch, so extraction of these teeth is an option, especially if the space creation is difficult. This is a removable appliance with T-spring to correct posterior crossbite of a single tooth, and this is a removable appliance with screw to correct of posterior crossbite of molar. This is a cross elastic, usually used with fixed appliance in order to move the opposing teeth in opposite direction. This is a short video showing how the cross elastic works. You can see that this cross elastic will move the opposing teeth in opposite direction in order to solve the crossbite. In case of unilateral segmental buccal crossbite, this could happen with two options, either with displacement of the mandible laterally or without displacement of the mandible. In case of displacement, That means there is a premature occlusal contact, which could happen due to narrowing or slight narrowing of the maxillary arch. So in this case, we need bilateral expansion of the arch, either by removable appliance with expansion screw, or with quad helix appliance, or by using fixed orthodontic appliance when a mild degree of arch expansion can be achieved using arch wire, or by appliances like transpalatal arch. In case of there is no displacement of the mandible, this can be achieved or can be corrected by unilateral segmental expansion of the arch. So, if there is no displacement, we need a unilateral expansion only on the affected area. This is a removable appliance with expansion screw. This is a coffin spring, can be used for expansion, and this is an expansion screw. This is a quad helix, and this is transpalatal arch. This is an expansion screw used with removable appliance for segmental correction of unilateral crossbite. You can notice that this will be correcting only the affected side. So this can be used when we have unilateral buccal crossbite without displacement. You can see now a removable appliance with expansion screw how will expand the upper arch. By turning the screw with the direction of the arrow, the appliance will be expanding and pushing the teeth buccally. So, with this movement, the crossbite can be corrected. Now you will see the quad helix, how it works to expand the arch. You can notice with the quad helix we have 4 helices, anterior and posterior. Opening the anterior helices can make posterior expansion, and opening the posterior helices can make anterior or premolar expansion. Now, treatment options of bilateral buccal crossbite. The first option is acceptance with no treatment, because usually bilateral buccal crossbite is stable with no displacement and it is functional. However, in severe cases, we can use rapid maxillary expansion, Hyrax for growing patient, or surgically assisted expansion with Hyrax for adult. In patients with repaired cleft palate, stretching of the scar tissue is often indicated using a quad helix appliance. However, be aware that treatment of bilateral crossbite without displacement should be approached with caution. This is for 2 reasons. The first is any partial relapse happen after treatment, this can result in premature contact and developing of unilateral crossbite with displacement. And secondly, as I said, in case of bilateral crossbite, it's usually efficient in chewing because there is a normal buccolingual relationship of the teeth. However, it's in reverse position, but it's still efficient during eating. This is a case of bilateral buccal crossbite. This is a rapid maxillary expander, the Hyrax type. And this is also a rapid maxillary expander, Haas expander, and this is a rapid maxillary expander which is called Isaacson expander. This is a surgically assisted expansion with Hyrax in which the mid-palatal suture is cutted and it's expanded with Hyrax. In case of cleft palate, we don't have a bone, we have a scar tissue. So this scar tissue is best expanded by using a quad helix appliance. This is expansion of the upper arch using Hyrax rapid maxillary expander. It also has a screw, and by turning the screw, the upper arch will be expanded, and you can notice in this appliance there will be a development of median diastema during expansion, which is usually closed during the use of fixed appliance later. And this is a Haas type rapid maxillary expander, which has the same idea by opening the screw and expansion in the arch, and it's also a rapid maxillary expander, which is more powerful than removable appliances. This is surgically assisted expansion with Hyrax. In this case, a surgical cutting of the mid-palatal suture will made before the expansion in order to facilitate expansion of the upper arch. Correction of lingual crossbite usually difficult to be achieved with removable appliance, so in most cases we need fixed orthodontic appliance to correct lingual crossbite. You can see this case with lingual crossbite, how the segment of the lower arch is tilted lingually, leading to the development of lingual crossbite or scissor bite. Slow versus rapid expansion. Appliances used for dental expansion usually are slow expanders, while appliances used for skeletal expansion usually are rapid expanders. In case of slow expansion, the appliances that we have either removable appliance with jack screw or expansion screw, coffin spring, quad helix appliance, fixed orthodontic appliance by using the arch wire or transpalatal arch, and in case of rapid expansion, we have rapid maxillary expanders like Hyrax, Isaacson, or Haas type of expanders, or surgically assisted expansion using rapid maxillary expander that can be used to correct skeletal posterior crossbite in adults. So these are slow expanders and rapid expanders. Slow expanders used for dental expansion and rapid expanders usually used with skeletal expansion. Appliances used for dental expansion or slow expansion. The first appliance is removable appliance with jack screw. It can be used in both arches and usually activated by turning the screw 1 or 2 quarter turn, which give us 0.25 to 0.5 mm per week. Coffin spring, which is another type of dental expanders for slow expansion. This can be used for unilateral crossbite and usually activated by pulling the two parts of the appliance apart manually or by using a special pliers at the base of the omega wire. Quad helix appliance can be used for cases with slow expansion and for cases with cleft palate. It can be fixed or removable, and you can see that it has 4 helices. The anterior 2 helices can be used or activated to give us posterior expansion, and the posterior 2 helices can be activated to give us anterior expansion in the premolar region. Also, it can be activated by using a 3-nose plier. So if the 3-nose plier used for the anterior arm, this can expand the appliance posteriorly, and if it's activated the lateral arms, this can be used for expansion in the premolar region. Transpalatal arch can be used with fixed appliance in order to expand the arch, usually by opening the U-loop in the transpalatal arch. Now appliances used for skeletal expansion or rapid expanders. The first one is Hyrax Rapid Maxillary Expander. These appliances are considered as a dentofacial orthopedic appliance which associated with heavy force and acting by splitting the mid-palatal suture and using the teeth to transmit the force to the palatal shelves in order to produce skeletal changes. So they acting by applying heavy force, which can be split the transpalatal suture, and therefore you can see a diastema during this expansion. Another types of rapid maxillary expanders are rarely used nowadays, like Isaacson rapid maxillary expander and Haas type rapid maxillary expander. Activation of rapid maxillary expanders, usually by turning the screw 1 to 2 quarter turn per day. This gives us 0.25 to 0.5 millimeter. So unlike the removable expanders, this activation is usually per day, not per week like the removable appliance. Usually a diastema appears between the central incisors as the bone separated in this area. And usually expansion should be continued until the maxillary lingual cusps occlude with the lingual inclines of the buccal cusp of the mandibular molars. Retention following rapid maxillary expander therapy. After achieving the desired expansion, the appliance should be kept in place for a 3-month period in order to achieve the retention. So this appliance should be kept passive without any expansion during this period. After that, we can use a removable retainer that covers the palate after the 3-month retention period. Or if there is a continuation in the treatment with fixed appliance, we can use transpalatal arch to provide retention during this treatment. So after achieving the desired expansion, we can use a composite to cover the screw in order to avoid any accidental expansion during the retention period. Notes related to this lecture. Unilateral buccal crossbite with displacement may be associated with centerline shift in the lower arch in the direction of the mandibular displacement on closure. So you can identify if the unilateral buccal crossbite with displacement by this centerline shift. Expansion of the upper buccal segment teeth will result in some tipping down of the palatal cusp, and this may increase the lower facial height. So if this is not required or not desirable during treatment, we can use buccal capping of the buccal teeth during this expansion to avoid this palatal cusp tipping. Or alternatively, we can do some buccal root torque for the molars after expansion. For correction to be successful, there should be a good post-treatment overbite for stability. Overcorrection and prolonged retention after expansion is mandatory for stable results. Crossbites in the deciduous or mixed dentition may result from premature contact between the deciduous canines with a resultant lateral mandibular displacement. So, we can treat this by grinding the canine tips to eliminate premature contact, but this should be just confined to the enamel part of the tooth. This is the end of this lecture. Thank you and good luck.